13 votes. And so the Democrats are already gearing up their campaign issues for the congressional elections. And the Republicans will be looking around for a rebuttal. And one of the elements that either side could use really is a lot of the information that happens to be in the book we're going to discuss today. Paul Dutton has done a remarkable amount of work looking at not just the healthcare systems of two major industrial countries as they are today, but as the way they evolved since roughly 1915, and what choices were made, how those choices have worked out, how they are paid for, or in some cases not quite paid for, and so forth. But there are significant implications for current policy choices here, and I think also in France. Paul was a fellow at the Wilson Center in 2004-2005. He is affiliated as a scholar with the Brookings Institution as well, and a research fellow for Health and Human Services, for the Health and Human Services Agency, and for Healthcare Research and Quality. He's in the process of setting up a program at Northern Arizona University where he teaches on healthcare policy, and I think that would be a very good initiative. Paul will introduce the major points of his book, and then we will have a commentary by Kimberly Morgan, who is Assistant Professor of Political Science and International Affairs at the Elliott School of George Washington University. She received a doctorate from Princeton. Her teaching interests include European politics, comparative social policy, women in politics. She's currently working on a book on child care policy in advanced industrial societies. So both of our speakers have engaged in the very demanding work of comparative analysis. And we all think that this pays off well in the quality of the analysis you get, but the investment at the front end is high, particularly when you're in a tenure track system where sometimes you get evaluated by the number of pages, not necessarily the quality that's in those pages, but that's for another time. We're very pleased, Paul, to have you come back, and Paul has just taped a show of our television program, Dialogue, which will show in a few weeks on MHZ channels in this area and in other public channels around the country. But we're looking forward to hearing Paul give the highlights of his book, and welcome back to the center.
Thanks a lot, Sam. It's really great to be back at the center. I've just been milling around here, and some of you know your way around here also, and it's just a wonderful place. I just can't say it enough how much joy it gives me to come back, especially under these circumstances, to present really the work that I completed, much of it here at the center. I want to just try to hit three themes, really, that reflect the book's arguments and main points of evidence, really. And the first one is I want to spend a little bit of time deconstructing socialized medicine. And I'm going to do that, and I use that term, of course, specifically to how, as an epithet, it's used as an epithet in American discourse about healthcare. And so I wanted to talk about it a little bit, because I hear it a lot in my own work. Secondly, I dig into the history a little bit. We'll talk about how both of these systems became linked with employment, and how I believe that that's a very unfortunate historical artifact. And then lastly, I'll just offer a few historians' sort of views on current reform proposals and the way forward, given a reckoning with the past that I do in the book. But if you don't mind, I'm going to start by just the little section, the first of three sections about socialized medicine, by just reading the first paragraph of the book, which is very journalistic. So it has a little byline here. Washington, D.C. I'm attending a goodbye party for a friend who is leaving her job at a local museum. A friendly group has gathered in a fashionable Northwest restaurant for drinks and hors d'oeuvres. I find myself face to face with an art historian from the National Portrait Gallery. I get the standard question, "What do you do?" I tell the interrogator that I'm writing a book on U.S. and French healthcare. "Oh, really?" he responds. "Theirs is government imposed, isn't it?" Another scene, Flagstaff, Arizona, a Halloween party for kids, mostly of faculty from Northern Arizona University. I'm talking with a biologist. She asks about my research. I say it's on healthcare in France. I pause for the reaction, to which by now I've become accustomed. She replies, as if on cue, "You mean socialized medicine?" Back in Washington, at the Brookings Institution, a public policy research institute. It's intermission at a conference on transatlantic relations. I've just met a French businesswoman. She's curious about my work, so I recount the two scenes above. "Socialized medicine," she exclaims in English. "That's the British." I tell the little story here in the beginning of the book because it's really something I ran into, obviously, and I felt it important enough to include, that I think there's a great misconception among Americans about what socialized medicine might be and why it is that all healthcare systems outside of the United States must be it. So let me ask myself the question, as part of my little presentation here, why the reaction from the French businesswoman? Well, I think why she was so surprised that French healthcare was being labeled as socialized, because, and in contrast to the British, of course, the vast majority of French ambulatory care physicians are in private practice. Many of them can fly solo in their own practices with very little back office billing staff. It's not uncommon to walk into a French physician's office and you have a physician, or maybe a receptionist or something else. Far more so than in the United States, patients have free choice of physician. Now that Americans have been sort of quarantined into provider networks. And what the French call a service de santé, right, this idea of a national health service, they view that as socialized medicine. They view that as inimical, if you will, to a great degree, I would argue, as inimical to the nation's, the national values. In the same way, I'm trying to compare it to how Americans, and I do so in the book, how they view the notion of socialized medicine. It's sort of antithetical to La République, right? One other thing is that the average French physician in ambulatory care has more control over clinical decision making. Again, if you're comparing with the American case. And then lastly, the French hospital sector, although it's primarily in the public sector, composed of these large sort of academic medical complexes as well as regional hospitals, still 36% of all acute care beds in France are in the private sector. So that there is a conception there, I think a misconception on the part of Americans that, at least on the supply side here, that French medical care is largely in the ambulatory care sector in private practitioners' hands. So one more question then about socialized medicine. If it doesn't have to do with whom the doctors work for, other providers, then does it have anything to do with finance? Okay. Well, because if you're defining socialized medicine as a system in which the government finances more than most of the healthcare, well then you have to sit back and say, well then both the French and the American systems are socialized. Okay, the French, of course, in a way, they're the mirror images of each other. The French have a system by which Sécurité Sociale, the large public insurer, pays about 77% of healthcare expenditures. 13 are paid for by private, nonprofit, or for-profit insurers, and about 10% out of pocket in France. So 77, 13, and 10 in each of those categories. These are round numbers. And in the American case, though, you have the federal government in this country combined with state governments, the Indian Health Service, the Veterans Health Administration, together paying about 46% of healthcare expenditures in this country, right? 39% are being paid for by private insurers, whether not-for-profit or for-profit, and then Americans pay about 15% out of pocket. Now, but, of course, the great caveat here is that what about the tax deductibility of health insurance premiums from employer groups? If you add those in, and they've been growing at 9% a year since 1998, the value is $200 billion and growing. Then if you add those in, then in fact that pushes the United States over the top because tax deductibility is a form of government subsidy. And so actually if you add those in, which I think you ought to, then more than half of the healthcare expenditures in this country are coming from the government. And if you don't want to add in the tax deductibility of the insurance premiums, then you only have to wait till 2014 when just counting the straight expenditures will do the trick. So I mean, all of this points to really, for me in the book, as I went through it and charted the history of healthcare systems comparatively from about 1910 up to 2005, is that there's an irony here is that the Americans' historical attachment to private employer-based health insurance, as long as that continues to hold, then we will increasingly socialize, if you will, our healthcare system. That's the irony, right? Because more and more people are losing coverage, and they have very little place else to go, nowhere else to go except for public programs, and of course they face financial ruin at the same time. So if we get to that point of 2014 and 2015, and we have near on 50-some million people uninsured, and we'll definitely have a system that resembles the French. It already resembles the French, but it'll be far more so than it is today. Let me turn to the second theme here and talk a little bit and dig into the history now a little bit more about the book and one of its main arguments, which is the link between work and health security. That is this employment-based coverage. It's an oft-repeated, rather well-known story, and read it in newspapers that when they have time to answer a historical question, that the American healthcare system and its tie to employment grew out of the Second World War. Well, yes and no. It certainly expanded greatly in that sense during the war, but it didn't start there. Right? You can go back into the 19th century and the early part of the 20th century where French and American, and this is the interesting part of comparison, in both cases, the healthcare systems were rather, where I start the book, I have this conversation between an American and a French physician on the Western Front, in 1917, and it's fictitious, I make it up, but it's rather typical, I think, where you have the French physician is talking to the American physician, and they're sort of, and I can, because there's a British soldier standing there and the Germans are on the other side of the barbed wire, I sort of start comparing the four systems at the same time. And the two most similar systems, of course, are the French and the American. And because you had a primarily, in terms of health insurance coverage, health security, how you want to look at it, both of them relied heavily on not-for-profit, whether they were mutual societies in France or some sort of fraternal orders, fraternal societies in the case of the United States. And that's where, if you were a stably employed man, unlikely you could get it if you were a woman, you could get some sort of coverage through these health insurance clubs, oftentimes associated with your employer or your employer group of some sort of socio-professional group. And this, of course, has sort of evolved in France in a very interesting way, because now the French mutual societies continue to play a very important part in France's healthcare system. Right? You have a large public insurer that was created at the time of the Liberation in 1945. However, the mutual societies continue to exist. They call them les mutuelles, as supplemental insurers, and they still work through the employment link, right? And this is what's very interesting about the French case, is because, and why it's so comparable to the American, is because in addition to the ideals that I mentioned earlier, where, if you ask Americans and French, I think, line them up and say, what are your ideal things about healthcare? They're going to say patient choice. They're going to say, a physician, that is. They're going to say doctors' clinical freedoms and things like this. And this is also something that when the French had a chance to do away with the link to employment at the time of the liberation in 1945-46, they didn't. Right? They left wage levies, payroll taxes as their main way of financing their healthcare system. However, les mutuelles, these mutual societies that had been so important in running the healthcare system prior to the war, remained as supplemental insurance. They were accommodated in that sense. Now, in recent years, I'll just make one quick comment about France and the tie to employment nowadays, and more recently, and then I'll move to the U.S. case a bit. Is that the French have been they've been decreasing actually the wage levy for workers, and it came down from 7, and now they're down to about 1% for employees, and employers are paying a straight wage tax of 13%. Right? That, of course, they've been transferring the cost of that onto a broad-based sort of income tax, if you will, the CSG. And I think that that's something where the United States should look at, because as you look at the American case, what you see nowadays is a system where according to the best studies, between 25 and 45% of the American workforce suffers some sort of job lock because of health security issues. That is, a worker does not want to look for new employment or take a different job because she is concerned about a pre-existing condition, either for herself or a member of her family member. Now, I'm no economist, but I've taken enough courses to know that if you don't have workers looking first and foremost for the best return on their the best return on their skills, your standard of living of the economy you're talking about is going to fall quite necessarily. And I think that's probably one of the biggest reasons why this country needs to seriously look at moving the finance of healthcare away from the link with employment. And that's why I call it in the book, this unfortunate historical artifact, which is all very well explained. I mean, right? I mean, you had in France, think about it for a minute, what I've said already. You had in France the mutuelles, right? These not-for-profit sort of public service organizations. You had in the United States these not-for-profit fraternal orders, and then, of course, Blue Cross comes into existence in 1932, again, a not-for-profit public service corporation. And Americans, like the French, were very comfortable with that. They didn't want the National Insurance Act in Britain in 1912-13, which caught on very quickly in Britain. The French didn't want that. Americans didn't want that. And nor did they want, let alone they didn't want a national health service, which the British, of course, created just after the Second World War, the Beveridge Plan and all this. So these are very interesting commonalities in terms of, I deal with this in the book, of these ideals of liberty and equality and the tensions between them, and how the French and Americans are so comparable. And that's why I think that today you have the case where the French healthcare system is probably, I think, most helpful. I'm not just trying to sell my own book here, but because it's the least organized, I think, probably the least organized healthcare system which offers universal coverage. And I think its lack of organization explains some of its problems. I mean, the French are running a 12 billion euro deficit this year, and they've got some plans to patch it up and bring it down to 8, something like this, with a franchise, another euro for each doctor visite. But and so they're struggling to pay for this thing. But I think that what's interesting is that the Americans and French are confronting some of the same difficulties, and that's why I think there's certain ways that we could learn from each other. If those are some of the difficulties, let me just call attention to one of the very big differences, and then I'll move on to my last little third part there. This country, of course, moved away from not-for-profit insurers rather quickly after the Second World War. And especially a big part of that move that happened at the same time was the move from community rating that was being practiced by Blue Cross, and then of course Blue Shield. Blue Shield, of course, Blue Cross covered hospital. It was a hospital service policy sold through employers. And then Blue Shield covered, as many of you may know, physician services, right? And it was sanctioned by the AMA, supported by and anointed, if you will, by the AMA. But both of those programs moved away from, and were forced to do so, away from community rating of selling their insurance to experience rating. And that's a very important difference, and something that the French, there are some for-profit insurers in France that use experience rating. However, they do need to pay a surcharge for doing it. And it really, it makes, what it does is that if you allow experience rating to run rampant in your health insurance system, what it does is it predisposes the system toward exclusion rather than inclusion, right? Insurance companies spend tremendous resources deciding whom to insure and whom not to insure. And that's one of the reasons why when you see these numbers of, the Medicare or Sécurité Sociale for that matter, their overhead costs are 3-5%, and private insurers are 14 or 25, depending on what the sources you're looking at. A lot of it has to do with the tremendous resources being expended for actuaries and those kind of activities. In fact, there's one really quite prominent healthcare economist, Hugh Reinhardt, who wrote a great piece a few years back where he cast experience rating as the devil. The whole thing is an allegory. It's the devil in the American and healthcare system, and I really do think his argument is quite accurate. We can talk more about the difference between community and experience rating if you'd like in the question period. I'd be glad to elaborate there. Let me go to my third section here, which are some recommendations for healthcare reform, and I'll concentrate on the U.S. side and pick up the French perhaps later in the Q&A after Kimberly's had a chance to make her comments. If we're looking at the French case for trying to learn, right? I think we can look at France and see that there were two grand historical bargains that were made, right? The first one had to do with their physicians. Spent a fair amount of time in the book talking about that. And the second one with their insurers. And I think if we did a little poll in the room today and we said, well, where are the vested interests in America, that are battling over American healthcare reform or stopping it, or we would probably name at least those two among others, but those two would definitely be mentioned. Looking at France, in 1930, they passed their first law for compulsory health insurance. It only covered industrial workers, but that was a very important part of the workforce, densely unionized and very powerful. And at first, physicians were opposed to it because they wanted fee-for-service medicine. They wanted to continue with their clinical freedoms. They wanted to become like lawyers, and they wanted the same status as une profession libérale, right? A real free profession that could charge rates that it thought necessary. So ultimately, though, they compromised. And they compromised along the following lines, is that physicians were able to continue to bill fee-for-service. Patients were guaranteed the right to choose their own provider, and medical confidentiality was protected. And that compromise really created, if you will, sort of a constitution. And there was even called the Charte Médicale, right? It was this medical charter that they argued about in the 30s and the 40s, and they still talk about it sometimes today. If you read the medical journals in France today, the physicians will still hearken to that. So that was the first compromise that was made, and it's not dissimilar actually to the compromise. I think there's a comparison here, since I'm in the business of making comparison I don't do this in the book, but it is that, I mean, the AMA was opposed and spent millions of dollars fighting Medicare legislation in 1965, right? And now physicians actually find it rather acceptable because it was a compulsory program, but it allowed them to continue with what they called in the 1960s, beginning in the 1960s, at the time of Medicare, usual, customary, and reasonable fees, which tended to be rather inflationary, right? So there isn't a comparison there if we're looking for the French case of how doctors may, today, I don't know, maybe that would be a point of discussion in our seminar today, about to what extent physicians are unhappy and willing to perhaps make a compromise with along the lines that the French physicians did in 1930. The second, of course, compromise that has to do with the insurers, and I've already alluded to it. The opponents of this first 1930 compulsory health insurance law were also these mutual societies. They didn't want anything. I mean, they were founded on the notion that health insurance should be, or health protection, health security, illness insurance, whatever you want to call it, should be a voluntary endeavor. I mean, in French they say prévoyance. This is this word that's very difficult to translate, but that means something to the extent of sort of foresight for yourself and good citizenship all at the same time. You're looking after yourself and your family. So the mutual societies, though, they ultimately compromised because they could see that it was in their members' interest, for one, to continue as insurance carriers, even if it was working with the state. But it also turned out to be a great compromise, I think, for the French population, because, again, a comparison with the American, I think that for a polity, that was otherwise sort of opposed to government intervention, at least heavy-handed government intervention in the field of personal health care, the idea of having a mutual society as an intermediary, now this is in the 1930s, was acceptable. I mean, in other words, compulsory health insurance came first to France, clothed in the form of mutual societies, which were these not-for-profit public service organizations. So that's why I think that today, of course, you have in France this relatively unorganized universal healthcare insurance system in which you have physicians who are still very powerful in the system. There's an argument now today over their trying to, we have the same problem because I can tell you I'm living now in a rural part of Arizona. The French have, as many of you know that keep track of the French press, they have there's an unequal distribution of physicians in France, from the Paris metropolitan region and other metro regions to the centre, where you have not enough doctors, and so they're trying to even that out, right? They're trying to say, well, we're not going to allow as many physicians in the metro areas. And, of course, the physicians are marching in the streets, and you still have the mutuals that are still there, a very powerful force, and I think that helps explain some of the challenges that they face. But the French, I think, buy into this system, very popular in France, at least up to the present, and about almost 90% of them have this supplemental insurance. I think it's about 86% carry a mutual of some sort, either through their employer or they buy it as an individual policy. So I think there's some things there that we could look at in terms of the grand bargains. I think I'm going to go ahead and stop there and let you have your little spiel.
Okay, Kimberly.
Great. Wonderful. Well, thank you for having me. This is a delight to be here speaking about this book, and I wanted to just thank Sam in particular for compelling me to read this book, and by compelling, I mean it's certain that I would have read the book at some point. I probably would have read it in some hurried fashion before running off to class or when I'm writing a conference paper, and I wanted to harvest some information out of it. But this really gave me a chance to read this book very carefully and comprehensively and really ponder its many lessons. And it really was a wonderful opportunity, I think, to read what I found it to be a thoughtful, probing, wonderfully written, and clearly argued book that is just packed with insights about the various dilemmas of healthcare systems in France and the United States, but really there are many lessons for many countries around the world. So I found this absolutely extremely insightful, and I learned a good deal from it. In addition, I found this book really vindicated the project of comparative history, in that it really displayed the richness that follows from when one analyzes a historical trajectory comparatively, making apparent similarities between countries that one might never have thought about if one was studying that country in isolation, but then also drawing more starkly differences between countries as well, and highlighting precisely which differences were particularly important or are particularly important for the question at hand. On the theme of similarities, I want to just comment a bit on some of the very striking similarities that came out of the book and that I found really intriguing. In addition to the similarity between the French and the American systems that Paul was discussing about this linkage between employment and healthcare, which is very important, there were a number of other ones, including the way in which both countries have struggled to reconcile the goals of liberty and equality. And in the case of healthcare, that's been manifest in the debate between preserving private practice medicine and all its liberties versus expanding the government role in healthcare to assure equitable access, and that this has been an ongoing theme and a way in which debates around healthcare have been framed in both countries. In addition, the struggles around cost containment of healthcare that Paul describes have been very much common to both and are continuing today, will continue on in the future. And then third, really the struggles between the state and organized interests, and even also between organized interests over healthcare. And these interests have an enormous stake in how healthcare is operated. Particularly, one of the most important interests is obviously doctors, but also labor unions, employers, insurers. These are all actors in both societies. And what you see in the tale told about the evolution of healthcare in both countries in the 20th century is a sort of constant tug of war, frequently between these groups, but then also between them and the state. And so it was very intriguing to see these similarities drawn out in the kinds of battles that have often been waged between these groups. If there's a sort of important overall lesson that I think one should draw from comparing the French and the American case and thinking about similarities between the two cases, it's really to put to rest this rather silly idea that we hear all the time that the U.S. healthcare system is different from the healthcare everywhere else in the world because we have a market-based healthcare system and everybody else has socialized medicine, and therefore that we don't need to pay any attention to what's going on anywhere else. And I think what Paul's book really shows is that, as he described, France does not really have socialized medicine, nor do many other countries in Europe or in other advanced industrialized states, but also that the U.S. doesn't really have a purely market-based system, that the role of the state is extremely important in our system, and that calling it market-based is really misleading. But that instead what we see is everywhere a mix of public and private provision and payment in healthcare, but that countries can really be arrayed on a spectrum in the degree to which public or private is more preeminent. And that this is a much more useful way of thinking about healthcare than this simplistic dichotomy between a market-based system and a socialist system. And I would hope that now that we seem to be on the verge of having another big healthcare debate in this country, depending on what happens in the 2008 election, it would be nice if people out in the wider world could draw this lesson and we could cease talking about healthcare in this kind of dichotomous way, although I'm not hugely optimistic that will happen. So I wanted to raise a couple of issues that I thought the book raised in my mind, and some questions to direct towards the author and perhaps also direct towards the audience. People are interested in these questions. And the first point I wanted to discuss is really about when it was that the U.S. and France diverged most markedly in their healthcare systems, and how we should think about what was really critical in driving that divergence. As I said earlier, I think what was really useful about this comparative historical project was to be able to follow the trajectory of healthcare debates and reforms, and really place those trajectories side by side, and thereby see what was, where were the critical moments at which France and the United States went down different pathways, because they really did, as Paul has indicated, start out very similar in their healthcare systems, but diverged. And what struck me as, I think, the critical juncture, if you will, was the period between about 1915 and 1935 in the two countries. And in the U.S., what's going on is a continual rejection of the effort to pass some kind of compulsory health care at the state level, after 1915 and into the early 1920s. And then also the decision in 1935 by the Roosevelt administration not to include health care as part of the Social Security Act. And the importance of these non-decisions in the U.S. is that it really opens the door to the development of private voluntary insurance, which then expands tremendously and will make it much harder to reverse course later on. By contrast, in France, the key is, I think, this 1930 law that Paul was referring to for compulsory health insurance that really kind of opens the door to expanding public involvement in the healthcare sector. And this really seems to tip the balance between public and private and start France down a different path from the United States. What struck me as really critical in each country in this juncture was the behavior of precisely the groups he focused on, doctors and private insurance companies, or private insurance actors, entities in each country, who seemed to make a calculation in France and the US about the merit of collaborating with the state, but reach opposite conclusions about this. In France, doctors and insurers decide that there's something to be said for actually collaborating with the state, for allowing some greater state expansion. And in the case of doctors, they think this will help them preserve a lot of the liberties that they care most about, clinical freedoms, confidentiality, and so on. And they think that by working with the state, they'll actually be able to preserve those freedoms. Similarly, the mutual aid societies think that there's something to be gained by this collaboration. Whereas in the U.S., doctors and the insurance industry, the for-profit insurance industry, vigorously, and some might also say viciously, combat any expanded state role in medicine, claiming that this is just opening the door to socialism. So I wanted to sort of push a little bit harder about why it was that they made these different calculations, why it was that doctors behaved in such a different manner in the two societies, why the mutual aid societies behave so differently from the for-profit insurance industry in the United States. In the case of the latter, it may simply reflect important differences between the commercial insurance sector in the U.S. and the mutual aid societies, who seem more like nonprofit actors with more of a kind of public orientation, at least from what I gather from the book. Whereas, of course, the insurance industry in the U.S. was one of the most vibrant commercial insurance sectors there was, obviously very concerned about its profits, always looking for new areas to expand into, and perhaps that explains why they were so fierce in opposing an expanded state role in healthcare. In the case of doctors, I wondered if it had something to do with the nature, actually, of the American polity versus the nature of the French polity and its political institutions. If doctors were not fearful that in the American context, given the incredibly fragmented nature of our polity, the multiple access points to different interests and so on, and the difficulty of really gaining control over the political system in any meaningful way, if they weren't fearful about any type of state expansion into healthcare because they feared they wouldn't be able to control where that would go once you open the door to state involvement. Whereas French doctors seem to display a lot of confidence about their ability to organize and lobby effectively to make sure that even if the state did expand its role in healthcare, they would be able to protect the freedoms that were most important to them. So that was just one thought that came to mind, but I think there could be other factors, and it's just interesting to explore and reflect upon why these interests behaved in such a different manner in the two systems. A second theme that I thought was really interesting in the book that I wanted to probe a little bit further was the notion of the struggles over healthcare as struggles between the competing values of liberty and equality, values that Paul traces back to the revolutions in each country, arguing that the French Revolution and the American Revolution both bequeathed a kind of ongoing tension between these two principles that then one can see clashing or in tension with each other through the healthcare debates. And I sometimes ask myself, in reading in particular the way in which doctors frequently called upon this idea of needing to protect liberties and so on, and thus resisting government involvement, how much of this was more rhetoric strategically deployed by powerfully vested interests to defend actually their pecuniary goals. It seemed in particular with doctors and other providers that claims about the importance of protecting liberty and choice were barely covering, sort of fig leaf, barely covering the real interests that were at stake, which was protecting their own income stream, their own material well-being. And this led me to wonder more generally how to think about the various ideas that circulate about in any major social policy debate. We've seen a lot of them circulating around town in recent months over the S-chip debate, for example, and how much these ideas are really that important in actually shaping decisions and outcomes, as opposed to being rhetoric that's mobilized by powerful interests to push particular objectives that they have. A third issue that I wanted to raise that really struck me in reading the book was another similarity between France and the U.S. that I think is referred to in the book, but I wanted to maybe sharpen it and highlight it a bit more because it really struck me as a commonality between France and the U.S. that helps explain why their healthcare politics look somewhat similar. And this was really the importance of pluralism, interest group pluralism in the two nations and how that plays itself out in the healthcare sector. And I started ruminating upon this when I was thinking about the issue of cost control, which has been so important in both countries, and in all countries face the struggle of how to control the huge demand for healthcare resources, but the need to actually ration those resources in some way to restrict access to those. And that politically, of course, that's an exceedingly difficult thing to do. And the way that other countries outside of France and the U.S. have dealt with this problem of how to distribute these scarce healthcare resources. Well, if you look at the UK, it's a really state-dominated system in which the state, through its global budgeting power, is able to effectively squeeze from above and control costs that way and thereby ration care through things like long waiting lists and what's often referred to as bedside rationing in the UK, where doctors simply decide they're not going to give care to somebody because they know the resources are lacking for a particular procedure or test. In a country like Germany, these questions are dealt with through a corporatist bargaining system, one which tries to incorporate interests into negotiations over how to distribute these resources. So it's a way to try to bring in groups and make them feel part of the process and really have them be equal actors in debating how to deal with cost control and how to distribute healthcare resources. But a striking parallel in both France and the U.S. in their struggles to impose cost control is that they're struggling to do this in a pluralist environment in which interest groups are decentralized, constantly fighting for access to political power, lobbying from the outside, frequently insecure about their ability to really control outcomes and so on. And what this leads to then is great difficulty in keeping the discussions about how to distribute resources rational and calm, with instead the temptation on the part of these interest groups basically to politicize these debates and make it very difficult then for these tough decisions to be made about how to actually ration care or ration resources. And I thought what was really striking in both the U.S. and French case was the weakness of the state in both cases in really coping with these interest groups. People often think about the French state as having a very powerful centralized state that can impose its will on these interests. But what comes through again and again in this book is the struggle of state actors to try to deal with these interests who I think are not only important because they have some financial resources at their side, but because they can really call upon public fears and mobilize public fears about particular policies, politicize the whole issue of trying to implement cost control and so on. And then that makes it very difficult for the state to achieve much reform. And I think one could see a similar phenomenon in the U.S., thinking back to the Clinton healthcare reform and the effectiveness of the Harry and Louise ads and mobilizing all kinds of fears about government health control. These interest groups, when they want to politicize the issue, healthcare is an issue that can tap a lot of powerful emotions out there. And so not having the ability to incorporate those groups in a way that enables them to negotiate in a kind of reasoned way puts us all at the mercy of this pluralist process that arguably doesn't always produce the best results. So the final point I wanted to make and kind of open it up to the audience for further discussion was about whether this comparative exploration of French and American healthcare has led Paul or anybody else who's familiar with these cases or other comparative cases to conclusions about what it is the U.S. might actually learn from other countries concretely about health policy that could inform what seems like is coming again in this country, large debates about the future of our healthcare system. I had the sense from Paul's conclusion to the book that he doesn't necessarily want to be drawing specific lessons from the French case, specific policy lessons, but uses this comparison rather to sort of point out critical issues that we'll face, sort of exposes misconceptions that both countries may hold about their healthcare system. But he does not, he opts not, I think, to go and give a list of things that the U.S. can actually learn from the French case. And I guess the question that struck me getting to the end of the book was, I just wondered if there are lessons that we can learn. Or is it that we've traveled so far down this other path and developed such an unusual healthcare system vis-a-vis that of other countries, and have such an unusual political system, that will it be hard for us to actually learn from other countries? Are there actually lessons that we can draw? And that's really just kind of a question that remains in my mind, whether or not the French case actually does offer us examples and ways to sort of reason through the various problems we face. And with that, I think I'd like to just turn it over to the audience and back to Paul.
Good. Well, thank you very much, Kimberly. That was an excellent comment, raised a number of points. Before we open it up to complete discussion, Paul, would you like to respond to any of the points that Kimberly made and make any additional comments on weakness of the state or turning points, why the U.S. physicians and insurance groups, many of which were run by physicians themselves, were so adamant against government intervention?
I mean, I really will limit my remarks, and I really liked your comment. It's very insightful reading of the book, and in order to answer them all, I need to take a half hour again, which I don't want to do, and I promise I won't. But one of the things, I'll just take one case, which will maybe bring out some of them. I spend some time in one of the latter chapters where I compare actually the Clinton healthcare reform efforts with the Plan Juppé. And as many of you are probably more familiar with the Clinton healthcare reform debate, but the Plan Juppé was something that followed. It was launched in November of 1995. And it was a reform that was broader than the Clinton healthcare effort. He wanted to do healthcare reform. He wanted to institute some sort of spending caps, as well as a tax to digitize medical records, and to institute gatekeeping primary care physicians in France. However, what's interesting about it is that that wasn't the main issue ultimately in the streets. What became the main issue was pension reform. And for those of you who may have been anywhere near Paris in 1995, late 95 and early 96, you couldn't get anywhere. And it was a mess. But the physicians, if we're talking about interest groups, they latched onto this. I mean, the physician, the Confédération Syndicale Médico-Français is no necessarily a friend of the large unions in France, but they were able to latch onto these street protests and ultimately kill the healthcare reform that Juppé was proposing. So there is this pluralism, and I think that goes to one other remark I'll make that get back to one of your earlier questions. In the book, I do go back to the revolutions. And this is the country, after all, of Jean-Jacques Rousseau and the volonté générale, that is this notion of the general will, and the notion, I mean, if you look at the revolutions, and I try to do this in summary form, but I do think it works, this notion that, and I quote de Tocqueville, which I have to if I'm going to write a comparative history of U.S. and France, is that, from the beginning of these republics, the state in France was necessary to create equality. That this country was rife with this aristocratic privilege, right? I mean, they executed the king and queen, after all, to try to rid themselves of it. And in the American case, of course, this is an anti-colonial revolt, a successful one, albeit, but they ignored slavery, right? We didn't deal with that until the middle of the 19th century, and still dealing with it. So there is, I think, a reliance in France on l'État, the French state, far more so. There's a predisposition in France to turn to the state. But at the same time, you still have these very, very deep-seated notions about equality and liberty that are comparable to the U.S. case. So I think it's a complex question, but it's a very interesting one because you have these two republics that tackle with those tensions, and it's very apparent in the healthcare field.
Thank you very much. Very incisive. Well, let's open it up for questions, comments. I'd like you to ask that you, one, wait for the microphone to come, because we are taping this and hope to have it posted on the website at a later date. And we would also like you to identify yourself before making a comment. Sonia?
I'm Sonia Michelle from the University of Maryland and a former Wilson Center Fellow, a nostalgic Wilson Center Fellow. I have two questions. One is informational and the other sort of builds on that. How is it that the French system is universal if it is based, or I guess the basic part is universal and then the supplements are based on employment? Is that correct?
That's right. I mean, well, if I go up to 2000, when they finally were able to cover everybody, right, what they did was they patched the holes, if you will, of anybody who had left out, who had fallen through the cracks in one way or another. And they did, it's a means-tested program, but they did extend some supplemental coverage also to those. Although it may not be as good, and of course it's very decentralized, like I said, it may not be as good as the mutuelle that you have as a teacher, which is a very good mutuelle, as it turns out. Yeah.
Okay, my second question, actually more of a comment, and that is you when you said that what was the, how do you put it, the unfortunate historical artifact of the fact that health insurance, like many other benefits in this country, is linked to employment, and you said it was because of, what's your term, this job lag or job block. And to me, the most problematic aspect of that linkage is not just job block, although I agree that that's a problem, but the fact that many people don't have health insurance through their employers. It's completely arbitrary. Employers don't have to give it. Women tend not to get it. Minorities tend not to get it. And increasingly fewer and fewer people are getting it or are having to pay more and more for it. So I wonder, if you would respond to that.
Very good. I totally agree. And I just wanted to emphasize something that I think is perhaps less known in the book, that as job lock occurs, it's so damaging to the productivity of the country. But the uninsurance rate, of course, exacerbates it as well. And I agree that there are certain groups that are more affected by it than others.
Jacqueline, the lady here.
Hi, I'm Jennifer Jensen from the Congressional Research Service. It's my understanding that as France has taken on recent reforms to deal with their growing healthcare costs, almost constant reforms it sounds like, one of the things that they've looked into is, or they've already begun to do, is they have a somewhat public-like or quasi-public entity that gathers information to help improve decision-making about providing care, maybe to affect coverage policy through the mutual funds or through the other types of coverage. And I was wondering how that's being received. It seems like the things I've read about that, it sounds a little bit like our comparative effectiveness discussion, and it seems to be a little bit ahead of us. And I was wondering, how's it going? Is it actually affecting the insurance coverage? Are the physicians complaining? What's happening?
Yeah, I can tell you that the French actually was the first country outside of the United States to test and deploy diagnosis-related groups, and so this goes all the way back to the 1980s. This hospital case-based reimbursement system, and it was at that time when they turned to this evidence-based medicine and best practices as a technocratic solution. And I think you are onto it. I don't think that it's the fallback to look to technocracy when the politics of it are very, very difficult. Because, as Kimberly correctly points out, any sort of, even the use of the word rationing in France, as in this country, no healthcare or political leader on the Hill or whatever, they don't want to use that word even, right? They want to call it something else. There's euphemisms here and there. So. And I don't know if I'm exactly answering your question, but I do think that the turn to best practices is a movement in France, And I also think that the doctors, though, they want to be involved. I mean, that's where if they're going to make progress on it, they're going to have to include the physicians' organizations.
Matt?
Thank you. I'm Charles Cobb with the Committee for Economic Development here in Washington. I want to commend both the speakers for an extremely lucid and clear presentation, and also thank Paul Dutton for writing the book, which I look forward to reading. I want to ask 3 questions. I'll try and be succinct. They're organized around 3 words: quality, incentives, and politics. On the quality question, Paul, you talked a lot about cost and access, but didn't say much about the relative quality of outcomes in the French system versus the U.S. system. I think a lot of Americans would be surprised to know that even though we spend more than any other country in the world, both in the aggregate and per capita, the outcomes aren't good: infant mortality, longevity, etc. So could you comment on the relative quality comparisons? Second, on the incentives, is fee-for-service sustainable in the long run? Because a fee-for-service system is basically driven by volume. And so the incentives are not so much to maximize the quality of the outcomes, but to maximize the number of visits. And on politics, the third question, we've just seen it played out today with the S-chip. One of my friends said that the Republicans want cost controls and don't want to do much about universal coverage. The Democrats want universal coverage, don't care much about cost controls. Where's the opportunity for compromise? Thank you.
Well put.
Yeah, that is. You know, on the quality question, I waded through, and I'm very thankful to, and I thank them in the preface to, healthcare economists and specialists in healthcare policy. I rely on studies in the book, especially I began the book with the World Health Organization ranking, right? France has very good outcomes in terms of infant mortality and longevity and disability outcomes. So I guess I think that I'm not as familiar with the comparisons maybe in the fine-tuned sense that you're interested in, and I don't want to sound as if I am if I'm not. So, but I think that in terms of overall sort of quality of life statistics, physical quality of life statistics, I think the French do very, very well in comparison to the United States. There's lower obesity rates, higher smoking rate, but I think that they do very, very well in and out of their in their healthcare system.
The longevity numbers are pretty much very similar.
They're fairly similar, but the French, I think, are still second only to the Japanese in terms
better,
of
yeah.
French women are the second longest living women on the earth, I think,
Yeah.
after the Japanese.
Yeah. Now, on the fee-for-service question, that's a very interesting part here. I agree with at least the implication, if not the statement of your question there, that, and I think the French are headed in the right direction, and I think that and Vic Rodwin up at NYU has written this, and I agree with him, that the French are in a very good position actually to create state-led managed care. That is, if you want to, especially for primary care physicians. I mean, that's where you don't have to have the entire medical corps working on and without being barred from fee-for-service or something like that. But if you can move a certain number of your primary care physicians to salaried positions, to capitated positions where they're not paid on utilization, that is volume, as you say, I think that you can save a tremendous amount of money, and you can also bring more people into the system. I mean, these two things, right, the quality and the access and the cost control and the coverage, they're all of a piece of this puzzle that have to be put together all at the same time. And the French, I think, are trying to do that right now. As you may know, there's certain incentives involved for patients and physicians to sign up as to a referring doctor, they call it, right? On the politics there, which was the last piece of it, remind me what it was that the last
little... The Democrats are said to favor universal coverage, but
yeah.
not concerned about the costs. Republicans, the opposite, more about restraining costs and not universality. And I think the S-chip debate is a tiny example
yes.
of that, on a smaller scale than with the whole 16% of our GDP that's accounted for by healthcare costs.
Yeah, I mean, I think there's something to that little, aphorism.
It's
or whatever.
overly simplistic.
Yes, I understand. I guess as somebody who looks at it historically, I don't think you can. You have to deal with them both at the same time, and to state the obvious there. And the SCHIP program ultimately is not an entitlement program, right? And it is something that could bring lots of children to health care. I think that if I want to comment on the politics of it right now, I'll say this, that all of these Democratic plans that are on the table, whether it's Obama, Clinton, Edwards, Richardson, they all have a public insurer option, okay? And that, I think, is the key to it, because that's the way you're going to bring coverage, and that's where, if I go back to my DRG comment earlier, the way Medicare cut down on expensive and over-generous and inefficient hospital stays in the beginning in the mid-'80s, which caused problems elsewhere, don't get me wrong. But I do think that having a public insurer option could both bring people in, and it would also set up a situation whereby democratically elected people would be responsible for rationing, okay? Let's say it. There is going to have to be some rationalization of this system if we're not going to bankrupt ourselves. The CMS released a study earlier this year that showed that this thing is going to cost us $4 trillion a year by 2016. That's 20% of GDP. I mean, and we're still not going to have everybody covered. So I'll leave it at that.
Gentleman over here, Jacqueline.
Thank you. I'm Mark Paterno with the Interactivity Foundation, and I'm very intrigued by this idea of the tensions between the ideas of liberty and equality, and I would think it would be interesting to take it a bit further and throw fraternity into the mix as well. But I was also taken with Kimberly's comment about liberty and about the rhetoric that people use to argue against socialized medicine in terms of liberty. And the idea as if the talk about liberty and freedom was one thing and a cover for something else, which was the notion of the ability to have a steady income stream to make money. And yeah, I would have thought that it's really just the same thing, or much more closely related, that our notions of liberty have always had a lot to do with the idea of property and the ability to acquire property, to keep property, to have property, to not have property taken by government and or taken away without just compensation. And I'm wondering what you think about that, Paul. I mean, is that the way in which you talk about liberty in the book? I mean, quite aside from whether or not there are places where you go overboard on defense of one value as opposed to another, is that the way you're thinking about it too, or are you thinking about liberty as being something different than property?
Mm-hmm. Well, I mean, I'd like you to comment also, Kimberly. Yeah. It's a nice. I've spent some time on the values, which are the great similarities, which makes it fun in a way. But I lay it out there as a tension to try to create a philosophical framework for the healthcare debates, and hopefully you understood that part of it. And I posed some questions in the introduction about, even in the case of, I can think of two cases just listening to you talk. I mean, for example, you go back to somebody like Sam Gompers, who was the leader of the American Federation of Labor back in the 1910s, when this first healthcare debate took place in this country, right? I mean, here's a guy who was a rugged individualist, a union leader, though, and parochial, though, at the same time. And so when he talked about liberty, he was interested in worker autonomy, right? This is what he wanted. He wanted the workers to be able to create their own organizations, provide their own health care. He didn't want the state coming in. So that's why the discussion of, and I hope you'll take this as part of my answer, this idea, this notion of Rousseau and the state in France viewed differently as it is here. People turn to the state to enforce liberty or to guarantee their rights, I think, more quickly in France than they do here. So I think that I agree that liberty, and of course when medical professionals talk about liberty, they're talking about practice liberties and the right to set up practice and the right to make money. Okay, so it's all this mixed together. I guess the last thing I guess I would say is that those who were in these healthcare debates, those who were arguing for compulsion said, wait a minute, if we take 1.6% of your, and that's what the numbers were talking about back in those days, if we take 1.6% of your wages, you're going to be more free because you're not going to have to worry about medical indigence, you see. So I'm glad you asked the question, and I hope that makes some sense. I do complexify it quite a bit.
Yeah, great question. That's very interesting, and I agree about the intertwining of political and economic liberalism in our society and in French society as well, and how difficult then it can be to disentangle necessarily those two things. My sense about how, from reading the book, about how the language of liberty and freedom was used was much more about physicians trying to preserve their autonomy, their clinical autonomy in their medical decision-making, trying to preserve patient choice of physician, which was a very powerful buzzword, remains one there, and has been powerful in our society as well, and also about protecting medical confidentiality, that those were more the ways in which specifically they tried to frame this conflict with the state and the importance of preserving medical liberties. And I think it was very similar, if I understand right, in the American case, so that even if what was at stake ultimately for them was about their material interests, they tended to always talk about these other, it sounded a lot better, I think, framing it in terms of patient choice and control over medical decision-making and so on. That was a much more agreeable rhetoric in both societies.
Kent Hughes?
Well, I have curious about.
Did you wait for the mic, Kent?
Kent Hughes at the Woodrow.
Trained.
At the no, here I'm asking people to do it all the time myself. I'm Kent Hughes here at the Woodrow Wilson Center, and I was curious about the ability to achieve much higher quality, or noticeably higher quality by some dimensions, while spending a noticeably lower percentage of GDP. And are there key points at which the cost structure deviates a great deal from the American situation? Might that be a way to learn? And as part of that question, I have read anecdotally that doctors are on average paid a good deal less in France than in the United States. And if so, is that a product of a greater supply, a larger number of immigrant doctors? What makes that difference?
An economist question.
Yeah. Well, I mean, this gives me an opportunity, of course, to go back to the community versus experience rating, right, and all the resources that are expended there. Because the administrative overhead, I think, of private insurers in the United States is very, very high. And so that, I think that's a large portion of the cost structure, if you will. And on the physicians and all medical professionals, I mean, I've seen varying numbers. I do know that in sort of broad terms, I think American physicians make about somewhere between 4.5 and 5 times the average American, wage, and French doctors it's more 2.5. Okay, so it's quite a bit less. But then again, let's complexify that a little bit, because I know a radiologist in France makes 4 times as much as a GP, as a general practice physician. So it's not all of one. How is it that they get there? Well, it has to do with the negotiations between the public insurers in France and the provider groups, right? The physicians' organizations or whichever you were talking about. And so those are negotiations that take place that decide upon the fees that are paid for the services being provided. However, back to the question that was asked earlier about fee for service, a physician can, by increasing the utilization, they can up their incomes. So that is, of course, a hole, if you will, in the French system, and I explains, I think, why the cost overruns in the French case. But I mean, in global terms, I think the best answer to your your question is that there's a tremendous amount there's a tremendous amount of concertation in France relative to the American case, even though it's one of the more loosely organized universal care systems, I think, in Europe and in the world probably. It still has a system by which they can prevent cost overruns in one sector being pushed into another. And a good example is in hospital payment. I mean, they adopted case-based VRGs where the public insurer pays for the diagnosis, not for how many days are in hospital. I mean, they moved to that system in a somewhat different way than the Americans are using it. But in the United States, what hospitals did was they just started discharging people to their own subacute care facilities where they could still charge on a cost-plus basis, you see. And there was no control of it. So I think the French, by having a large public insurer, can have been more successful at trying to hold down costs than the American. I mean, that explains, they still have cost problems, and I'm not up here saying that, and perhaps they're very, very serious, but they're still not spending 16% and going of GDP.
Yes.
May I just add something
Yes,
about
please.
physicians?
A moment. Yep.
Hi, my name is Joanna Kohler, and I work for the French American Foundation in New York. So, no, I just wanted to add something to what you were saying. It's not maybe an explanation in the discrepancy between the revenue of physicians in France and the U.S., but you just have to keep in mind that in France, medical school is almost free, so physicians don't have to reimburse the cost for 10 years or so, and also that you don't have as many malpractices suits as you have here. So these are two factors that should be taken into account as well. That's
Very good points. Yeah. Doris? Yeah.
Doris Brown, a scholar at Woodrow Wilson. I also wanted to say, I think perhaps there are more specialists in the U.S., and so therefore raising the cost in comparison to the primary care specialists, that you might have more primary care in France, and so there's a differential in the cost as well as a geographical differential.
Yeah.
Doris should identify herself more fully. She's with the National Cancer Institute at NIH, so.
Yeah. I mean, I think the latest numbers on that are almost 3/4 of the current medical students in the United States are in specialty. Should be an alarming number if you look at our needs. However, the French are they're moving toward, and I've even heard French advisors and commentators remark upon this, that their balance is shifting more to the American balance. It's not still there. I think it's still about half of their physicians are in general practice, but there's concerns there. Again, it has to do with this relatively loosely organized system.
Sonia?
If I could ask another question. My understanding is that a large part, I don't know what the exact percentages of American healthcare costs are spent on end-of-life procedures. Is that the same? Is the same thing true in France?
Yeah, about 60% of all healthcare expenditures go to cover about 10% of the sickest and most chronically ill. And it's about...
In the U.S.?
No, that's in France. And it's 20/80 in this country. So I don't, it's always hard when you're doing comparative work, as you know, to get the exact same stats. But I've just given them to you. It's very similar, yes. Why I think France has good cause to be very, very skeptical, as I think Americans should be, about this notion of consumer-driven healthcare, because you're trying to cut physician visits for minor ailments, which, as a proportion of healthcare spending, it just doesn't make very much difference. Most of the money is spent on the very ill and chronically ill.
Kimberly, any final word?
I don't have any final word now.
Okay, great. Well, let me, Mary, did you have a question?
Just
Yeah, sorry, didn't.
yes. Mary Mullen. I was just wondering, we're having now, I notice with the doctors that I go to, have physician assistants, so that the minor problems are given to the physician assistants, even though the doctors are specialists.
Yeah.
In certain areas, you can go to their physician assistants. Is anything like that in
I don't believe there is the same kind of talk about that in France. And I'd certainly welcome anybody in the room who's has some insights into this. But I don't believe there's the same kind of talk in France as there is in this country, unrealized in many cases here yet in this country. You do have the nurse practitioners and the physician's assistants, I think, which is should be a future trend here. France, though, does have a lot more emphasis on preventative care. I mean, if you look at the PME, right, for example, this is a no questions asked, state-run, but still employing private physicians place where you can go for well child care. And when I say no questions asked, no questions asked. For vaccinations and for medical visits, medical exams, et cetera. So I think there's another cost savings, Kent, I think, where you have a tremendous effort on prevention, which pays off, I mean, right, in the long run. So I'll leave it at that.
One other nice benefit of the French, which is not as widespread as it used to be, is that